This second short talk on arterial blood gas analysis will focus on interpreting oxygenation and the PaO2. If you haven't looked at the first lecture, the basics of blood gas analysis, I would advise you go back to that lecture first, and when you're finished, come to this one. At the end of this session, you'll be able to discuss the function of the lungs in gas exchange, describe the different types of respiratory failure, and interpret oxygen concentration on a blood gas in relation to the FiO2 and the clinical picture. So just a very brief reminder of what gas exchange is about. The lungs are important in regulating the concentrations of two gases in the blood, oxygen and carbon dioxide. These two gases actually behave quite differently in the blood and in the lungs. Let's start with CO2. CO2 is very soluble in blood and serum. Therefore, in many different circumstances, CO2 is able to dissolve in the blood and get to the lungs. Once it gets to the lungs, there is an equilibrium between the gas in the alveoli and the gas in the blood. And an increase in ventilation, which increases the exchange of gas in the lungs and therefore promotes the removal of CO2, increases the expulsion of CO2 from the lungs. Therefore, the CO2 level in the blood is very much dependent on our ventilatory function, the rate and depth of our breathing. If we are breathing deeper and faster, our CO2 drops because we get rid of more through the lungs. Whereas if we are breathing slower or shallower, then we can't get rid of the CO2 and it builds up. On the other hand, oxygen is much less soluble in blood and serum and has to be carried by a special molecule, hemoglobin. Because of this, the exchange of oxygen is also dependent on the concentration of oxygen in the alveoli and the ability of oxygen to cross the alveolar membrane into the blood. So whereas CO2 is mostly dependent on ventilation, or the CO2 levels in the blood are mostly dependent on ventilation, the CO2 levels, the oxygen levels in the blood are dependent on both ventilation and, well, on several things, on ventilation, on the concentration of oxygen in the blood, and on the ability of the lungs to exchange gases. As we will see, all of these things are important when we are discussing respiratory failure. So let us talk about respiratory failure. In general, we recognize two types of respiratory failure, type 1 and type 2. Type 1 respiratory failure occurs in a situation where there is normal ventilation, so the breathing mechanism is working properly, but gas exchange is impaired for one reason or another. Type 2 respiratory failure really refers to respiratory failure that has been caused by inadequate ventilation. So type 1 respiratory failure refers to a deficiency in gas exchange. In these patients, the oxygen level in the blood, the PO2, is low, and the carbon dioxide level in the blood is normal or low. Often low, because when people can't breathe and are hypoxic, they start breathing faster to try to get more oxygen in, and as we discussed earlier, faster breathing leads to a lower PCO2. On the other hand, type 2 respiratory failure is due to a deficiency of ventilation, so the actual breathing mechanism is not moving enough air, and in that situation we don't get enough oxygen into the lungs and into the blood. But also, because our breathing mechanism is slow, we can't get the CO2 out either. In this situation, the PO2, the oxygen in the blood, falls, but the PCO2, the carbon dioxide in the blood, rises. Again, the causes of respiratory failure can be looked at in terms of type 1 and type 2 respiratory failure. So patients with type 1 respiratory failure, that is low oxygen saturation in the blood, a low PO2, and a low carbon dioxide saturation in the blood, a low PCO2, can be caused by either low levels of oxygen in the inspired air. This can be seen in high altitude, for example, or a diffusion defect. Something is blocking the oxygen from going from the alveoli to the blood capillaries in the lung, and this could be due to any thickening of the alveolar membrane, as is seen in pulmonary edema, acute respiratory distress syndrome, or pulmonary fibrosis. One other thing that can cause low oxygen in the blood is ventilation-perfusion mismatch. This simply means that there are parts of the lung through which blood is flowing, but which are not being ventilated. So, for example, areas of atelectasis. Or alternatively, there are parts of the lung where ventilation is occurring, but the blood flow isn't getting to that part of the lung, for example, in pulmonary embolism. In type 2 respiratory failure, this has anything to do with something that slows down or inhibits normal mechanical ventilation. So, CNS depression, such as depressant drugs, strokes or head injuries, airway obstruction, either upper airway obstruction as seen in trauma or anaphylaxis, or lower airway obstruction, for example, in chronic obstructive pulmonary disease. Other musculoskeletal and neurological weaknesses can also cause CO2 retention, as seen in spinal paralysis or Guillain-Barré syndrome. If we're going to interpret a blood gas, therefore, we need to know how much oxygen is being breathed in. So we need to know the atmospheric pressure of oxygen plus the percentage of inspired oxygen. In normal air, that's with 21%. From that, we can work out something called the alveolar arterial difference, which is the difference between the partial pressure of oxygen in the air we're breathing in, or the air at the alveolus, compared to the partial pressure of oxygen in the blood itself. And there's always a little drop, but usually less than 20 millimeters mercury. If there's a higher alveolar arterial difference, it means that although there's oxygen in the alveolus, it's having a difficult time getting across the alveolar membrane into the blood. So intrinsic lung disease will cause an increase in the AA difference, or the AA gradient. In a normal person breathing air, the PO2 is between 100 and 120 millimeters mercury. This is a rather complicated equation to help you work out what the alveolar arterial gradient is for oxygen. We will come back to this. There are other ways of measuring diffusion capacity, or the ability of gases to get from the alveolus into the blood. And two simple ones are the PF ratio, which is the ratio of the PaO2 to the FiO2. The FiO2 is measured as a decimal point rather than a percentage. And the SF ratio, the ratio between the SpO2 and the FiO2. Okay, let's see if we can apply some of this now. The first case is an 84-year-old man with bronchitis, increased shortness of breath and fever. We saw him in the last presentation. So let's concentrate this time on his oxygenation. Well, his PO2 is low, we know that he's breathing room air, and his PO2 is 43, whereas we would expect a PO2 of between 100 and 120 millimeters mercury. This low oxygen in the blood is supported by the fact that his oxygen saturations are 85%. We expect a normal oxygen saturation to be anything between 94 and 100% on room air. Now we need to figure out whether this is type 1 or type 2 respiratory failure. Let's look at the PCO2. The PCO2 is high, so this would fit with type 2 respiratory failure and suggests that this patient has a deficiency in ventilation. They are not breathing well enough to exchange gas and to move enough air in their lungs. And this would fit with a story of bronchitis or chronic airways disease. Let's look a little further into this. So we said it was type 2 respiratory failure. We could have worked out his AA gradient from the initial formula. This is somebody breathing air, so we can say 150 minus 81, 81 being representative of the PCO2. Remember, PCO2 divided by 0.8, and you subtract that from 150, which is atmospheric oxygen pressure, and then we subtract that from the patient's actual PCO2, which is 43, and that AA gradient is 26, which is somewhat elevated. The causes in this patient would be lower airway obstruction, alveolar hypoventilation, and because the AA gradient is somewhat increased, we know that there's some underlying lung damage as well, which would be expected in a patient with COPD. What about this case? A 52-year-old man with acute shortness of breath. He has increased work of breathing, he's on 4 liters of oxygen, and we're going to assume that his FiO2 is 0.4 or 40%. His PO2 looks within the normal range, but remember we must interpret this in light of his FiO2. So in the next slide we'll work out whether he is hypoxic or not. Just to highlight that his SATs are low and he's breathing increased concentration of oxygen. Now is this type 1 or type 2 respiratory failure? Well, his PCO2 is low, so that suggests that he is hypoxic. He's actually over breathing, but still his saturations are low. And if we go to this slide, the AA gradient is very high because we would expect so his AA gradient is very high. It's 147 millimeters mercury, and it should be less than 20. This means that although he's getting supplemental oxygen, not in only a limited amount of that oxygen is getting into his blood. Similarly, his PF ratio and his SF ratios also suggest that he has moderate intrinsic lung injury. You can go back to this slide before and just see what the normal would be. So this suggests that this patient primarily has a diffusion abnormality. The oxygen cannot cross the alveolar membrane into the blood, as can be seen in pulmonary edema, ARDS, or fibrosis. If you have any questions, you may post them on the YouTube video, and I'll try to answer them. So just in summary, interpreting the PaO2 depends on the atmospheric pressure, the inspired concentration of oxygen or the FiO2, and the clinical presentation of the patient. And respiratory failure can be type 1, which is failure of gas exchange, or type 2, which is failure of ventilation. Well, that brings us to the end of our 2 little talks on blood gas analysis. Thank you.